Good evening, everyone. Welcome to our webinar, Ask the MS Expert. It's a part of the NIHR Ask the Expert series. My name is Dr. Agnes Trokiene, a neurologist at Torbay and South Devon NHS Foundation Trust. I'm also MS Service Lead. I'm also a lead of Southwest CRN, Clinical Research Network, which has collaborated for this particular event with National Institute of Health and Care Research to bring you this event tonight. The NIHR is a government-funded body that funds research in the NHS, public health, and social care. Before we begin, please double check that your microphone and camera is switched off. We don't want any unnecessary background sounds. You are able to post messages in the chat if you need to, and we will do our best to help you if you have some problems, technical issues. We have a support team helping us tonight. I'm delighted to be co-chairing this event with Professor Klaus Schmierer. Klaus is a professor of neurology at the Blizard Institute, Barts in the London School of Medicine and Dentistry, Queen's Mary University of London, and a consultant neurologist at the Royal London Hospital Barts Health NHS Trust. He's a director of clinical research across Queen Mary University of London and Barts Health, and also the research lead for neurology and the clinical lead for Neuroscience day case unit at BartsMS. We have received a large number of excellent questions. It's actually overwhelming from everyone who registered to this event. Due to the volume, we will not be taking further questions tonight because we have maybe 30, 40 to cover. However, we will be compiling written responses and to any questions we do not have time to cover during this event. And this will be published on the Southwest MS Research Network website. Actually, Toby is going to share the website link within the chat. And we will circulate to everyone who registered but couldn't attend tonight. And I can hear and I can see people still keep coming and welcome who are late. We are desperate to start very early, exactly at 5 o'clock, because we have a lot to cover tonight. This event is being recorded, and you also be sent a copy of this recording after the event. And I would like to bring into this conversation Professor Klaus Schmierer, and let's get started. I'm going to be putting some questions to Professor Schmierer, and of course also answering them together with him. So thank you everyone for joining us, and I hope you're going to find this event very, very informative, and you will adopt certain approaches and will be able to approach your local teams for joining the clinical trials that are available in multiple sclerosis. So we have segmented the whole questions into 3 segments. One is understanding progressive multiple sclerosis. Then we will move on to talking treatment advances and management strategies in multiple sclerosis. And we will finalize with living with MS lifestyle support and future outlook. So to open this conversation, I would like to maybe talk a little bit first. We received a question such as, is benign MS a different cause from other types of MS? For example, a metabolic syndrome. And we would probably start, Klaus, if that's okay, talking about what is the benign MS and how do we classify and phenotype multiple sclerosis? What does that mean, benign MS, to you, Klaus?
Yeah, thank you, Agne, and thanks everybody for attending. I was wondering whether we should run Ask Our Audience to start with, because I think we do have a little poll for this. So if that could be put up, brilliant. Yes, so it's a very simple question to those attending. Does benign MS exist? Yes, no, or maybe. So you can ask your question now. Let's see. 2 responses so far. Do you respond, Agne, as well?
Yeah, I can see that is 100%. People think there is a benign MS. However, this has changed now to 43, 38. People, 25, 1/3 thinks that benign MS doesn't exist, and around 40% they say maybe. So,
Let's see, yes.
yeah, it's
So
interesting.
it's still evolving, isn't it? So I think first, I think in terms of description, people generally describe MS that is benign as one where there's very mild or minimal neurological symptoms, that people recover from these symptoms very rapidly, that there's usually a long gap between manifestations and relapses, and very little remaining deficit as a result of the manifestations. And also, I think when we're looking at additional markers, biomarkers, generally speaking, brain atrophy, so volume loss of the brain on MRI, and neurofilament levels, which we can measure either in the serum or in the spinal fluid, are low. So all indicative of a less active or less severe disease. Does somebody who has benign disease always remain benign? I think that is the major question, because we know from studies that people, for example, who've been monitored for 15 years, who ended up with an EDSS of 3, so this is essentially somebody who, according to the traditional measures at least, is hardly disabled, certainly not limited in their walking range. If you look 15 years later, half of those have developed to an EDSS of 6.5. So they are essentially in two crutches for 20 meters. One could probably now throw in other biomarkers to help a little bit with that prediction. But I think when we're looking at the individual case, it remains a very critical decision whether or not to describe somebody as benign, because obviously when we're talking about benign disease, we're also looking at how or not should we adapt the intervention accordingly, and I think that's the big question, isn't it?
Yeah, I believe that benign MS can be, as a definition, can be very misleading. There are people who are very well functionally, so they can do various different things. They haven't experienced any relapse. They haven't got any disability. They can walk miles, etc. But if you analyze and go into precision and check their cognitive function and ask the question about the performance at work and how they're managing life and planning, you can see that there is a bit of a processing speed problem, a cognition problem. And EDSS, which is our sort of a score that we would assess patients in our clinics to define the level of disability, it may be 0, but the cognitive function might be declining over the time. So, and these people might be mistaken and labeled as benign MS, but I think we really want to be open and transparent and really get into people's profile and a bit more deeper. Of course, there are people who have milder symptoms and they haven't got any cognitive issues, but being conscious and aware of the mislabeled benign MS as progressive MS is really impactful and changing the whole sort of scenario, what we would normally do as neurologists if we identify somebody with a cognitive dysfunction and being labeled with benign. Would you agree with that?
I think it's going to be a fascinating and very interesting and important question henceforth, because with the interventions that are available now, the drugs that we have now, I think we are much more trigger happy, and I think for the right reasons, and for the time being, benign MS is really a retrospective diagnosis. Somebody who comes into your practice who has been diagnosed 20 years ago and for some reason has never been offered treatment, and yet is fully active, working, running marathons, etc. These type. So the question, in a way, I would have answered yes, but. It's really a big but, because it's maybe 1 out of 10, maybe 1 out of 20 who is so well, and to really extract those will be a big challenge.
Yeah.
So yeah.
I would like to add, because the question also was around metabolic syndrome and whether that's linked to MS. So the general answer would be there is no evidence linking benign MS specifically to metabolic syndromes. Although general health problems, metabolic factors can influence the course or symptoms of multiple sclerosis. If we're talking about somebody with diabetes, underactive thyroid, some obesity issues can influence the outcomes negatively with people living with MS. Getting a little bit, we just touched the basis on cognition, and there was a question about, is it possible to tell the difference between the cognitive decline caused by MS and cognitive decline caused by dementia? And if I could just maybe start answering that, Klaus, and you will add information. Differentiating cognitive decline due to MS from dementia involves various different evaluation and the patterns of cognitive deficit. That includes the patient history, conducting neurology assessment. Usually, generally speaking, MS-related cognitive decline typically affects processing speed and information, executive function, which is planning your life and doing certain tasks, multitasking. Also, attention is affected, where in dementia, people have more short-term memory issues and they have orientation problems. They get lost in the cities, towns, local places where they live, and they really struggle with that sort of recent information that if you say something, they forget the next second, where people with MS have a bit of different pattern of the cognition. That's how we distinguish dementia from MS cognitive issues. Would you agree with that? Anything to
Yeah,
add?
I think fundamentally, yes. I think it is that is really very much an individual question, because sometimes you do wonder when the sort of additional factors play a role. You do find people who have cognitive problems, but then develop clearly an additional syndrome that suggests a different course of their cognitive decline. And this is where I think biomarkers play a role. For example, looking at neurofilament levels, they can be very high in Alzheimer's dementia or in Parkinson's disease, etc. And but you know the diagnosis, the private diagnosis, MS, and then you intervene and treat, but the neurofilament level doesn't change, right? So this is, I mean, the strong indication that this additional factor plays an important role. Otherwise, yes, I mean, the syndrome varies, but I think everyone on the call who sees people with MS probably agrees that sometimes it can be quite difficult. Clearly, as you say in the beginning, cognitive speed, multitasking, these things are affected, and obviously other elements that play a role in MS, such as fatigue, play into it as well.
Yeah. So I think we finished with the first segment of understanding what is MS and how we identify MS, and that was a triggering question about the benign MS, which is really an interesting topic, and probably we need more research in this area. Moving on to, and I can see that our audience is buzzing. They all want to know about the medicine that are available and what the clinical trials are available. I'm very conscious of the timing, and I would like to get into the treatment advances and management strategies. And we have very interesting question here based on the experiences of your patients. One of the registered participants asked us, how would you rate the effectiveness and safety profile of siponimod? As you know, this is a licensed medicine in secondary progressive MS. So do you strongly encourage to use this medicine? And are there any other promising treatments for progressive MS that are likely to be available anytime soon?
Yeah, I mean, clearly, I mean, this is the compound that is currently licensed for people with secondary progressive MS. We in the UK or in Europe, there is, funny enough, there are obviously differences in terms of licensing with the FDA in the US and other jurisdictions, since the when regulatory approval was given, MS was slightly differently classified or perceived, whilst we're obviously now much more of the opinion that progressive elements are already playing a role very early in the disease, whilst inflammatory component of the disease also kind of is something that we see throughout. Now, siponimod clearly is an effective compound and one that I use, that many use in their clinical practice. Patients are entitled to that treatment if they fulfill the criteria, which means signs of disease activity, inflammatory disease activity, either relapses or on MRI. If there are no treatment, but have signs of secondary progression, patients who are already on disease-modifying treatment don't need additional inflammatory activity to underpin the indication for them to be put on this compound. Overall, the experience, I think, is positive. It's well tolerated. Obviously, there's the handful of potential adverse effects. I think the major shortcoming or complication, as it were, is not actually being on the compound, but what are you going to do if the eligibility kind of fades out when people are not eligible for it anymore, say in EDSS 7 or CF5? What do you do then? Because we obviously know that the disease can remain active, and if you then stop a compound like siponimod, an S1P modulator that then will lead to a essentially influx of lymphocytes into the bloodstream and potentially lead to disease exacerbation, even in people where who have more advanced disease. I think this is the major downside, as it were. But in practice, in its use, my experience is positive with it.
Yeah, I really encourage patients, the suitable candidates for siponimod treatment, if they have progressive MS and they have active disease proven by new changes on the MRI scan, or they're still experiencing relapses, it's top one medicine that is available and licensed to use within the NHS. So I think it's proven to be effective. Although we had a comment and a further question to say, I've got a secondary progressive and I am on this siponimod treatment, but I still feel like my MS is progressively getting worse. And I think we are heading a little bit into smoldering MS field. And I saw the question here in the chat. Can we discuss a little bit more about the concept of smoldering MS and what are the tools to identify? There was a question around using the PET scan imaging, using MRI scan to identify the changes of the progression of MS. So can we start talking a little bit the very saddened and unfortunate nature of MS, that despite all the interventions and all the treatments are available, there is still an element of gradual progression or chronic lesions become active lesions. Klaus, would you introduce a little bit to that concept?
Yeah, absolutely. I mean, I have a slide here which just illustrates how we see MS in the very beginning on MRI, and this is a time lapse of lesions emerging and then some of them essentially disappearing, which doesn't mean they completely disappear, but they are not detectable on our standard scans. When you look in pathology, I'll go back to this, then you obviously see that there is a little scar and probably a little bit of atrophy. So this contributes to the overall volume loss. This is something that we see in the beginning. So this is a blood vessel around which these lesions form initially. There's probably something happening even before that, but this is the most visible element, as it were, of lesion evolution that we look at scans. And this is what we can then see. There is microglial activation, so resident cells also from the periphery, but also resident cells that become activated and contribute to the damage here of axons and, of course, the myelin sheath around that. In more advanced MS, we do see that there's a compartmentalization of the immune system in the CNS, where there's less obvious pathology of this type, but clearly ongoing activity, and that seems to be driven not only by B and T cells, but by this chronic activation of microglia, and that has, which is part of the innate immune system versus the adaptive immune system that consists of B and T cells. And so this has really given rise to the concept of ongoing inflammation, something or slowly burning or smoldering inflammation, which is kind of illustrated here. And that again then underpinned this relates here to slowly expanding lesions. I don't want to go too much into that, not take away too much time, but rather look at, hang on, I have a slide, I think, here on a concept that has been put forward, that the treatment or focused treatment of not only B lymphocytes that we know are very much involved in driving the peripherally driven pathology of MS, but also microglia and macrophages. So this element of the innate immunity, we think, also plays a role, particularly in more advanced disease. Now, I'm highlighting here the BTK pathway, which is a treatment pathway from proton tyrosine kinase inhibitors, or compounds that have developed to target both these microglia and the adaptive immunity. And here's just an example of a trial that has been completed, seemed to be positive, but the subsequent phase 3 trial was negative. There's further compounds like this in development, and at quite late stage actually in phase 3 trials, and we'll see whether they perform better than this one did.
Wonderful. I think it's a nice explanation, and just to simplify the language, it might sound very complex, but yeah. So, but I think it is an element of our body cells that every single cell has got a role in our body, including microglia and macrophages. So these are sort of names of the cells, and they are like a firefighters. They should calm down the immunity. But they somehow fail to do that. And they start becoming active in our bodies by causing more inflammatory process, as we call sort of smoldering process, which is an activity within the long-standing chronic lesions. So the firefighters, like microglia, if it becomes active, they fail to diminish that flame and lose the battle, and as a consequence, people with these active chronic lesions, they have a cumulative disability. And there are fewer agents that can affect that microglia activity. And there are some clinical trials that are being conducted at this moment, looking at agents that potentially could tackle the microglia activation. So moving on to this note, I think we need to talk now around any improvements in secondary progressive MS treatment, or in general. Maybe we could say, maybe there is an advanced MS potential clinical trials that we are looking into. Any ideas on the clinical trials in progressive MS? What is available?
Yeah, I mean, I think this was one of the really motivations as well of this whole sort of webinar, really, to look at these. And this is obviously an area that I'm very interested in. We've already touched a little bit on it, and of the fact that I think the perception of more advanced MS has changed over time. we have become much more aware that whilst the inflammatory response that I tried to illustrate earlier on with the many lesions appearing and then disappearing, and that kind of fades out over time, that kind of suggests that inflammation is kind of gone. But we know now, I think, much better that even in people who have passed away with MS, they still have, in about 80% of cases, active inflammatory lesions. So, and that can't be good in MS. We know that the inflammation very much drives the disease process. It's not the only element, of course, but it is an important one, and it is one that we think we may be able to address even in later stages. And if you let me, I'm just going to show a few slides around Chariot. I'm obviously sitting here with my T-shirt, and people will forgive me that I sort of give this little plug on the study that is called Chariot MS. So this is, and I will, although I speak about the trial, I'm very keen that people appreciate that this is testing a concept which is effective inflammatory therapy at an advanced stage of MS, and it obviously addresses one of the top priorities of the MS Society's James Linder Lines, which, if it works, will also affect a number of the symptoms that we associate with MS: fatigue, mobility, cognition, etc. Okay, because so it is very much based on the concept that progressive MS, that MS is progressive from onset and inflammatory throughout. I've already illustrated this, and specifically in this trial, we are focusing on people who are largely wheelchair users. So they are maybe able to still walk a few steps on crutches, but we are focusing on those who want to protect upper limb function. And the reason why we think this could work is related to two concepts. One, MS is inflammatory throughout. I already mentioned that. And two, that the length of the central motor system, central nervous system tracts impact on how often they are being hit by lesions, and therefore longer tracts are more vulnerable and therefore damaged earlier than shorter tracts, for example, for upper limb function, for visual function, and others. This is something that has been recognized even by John Kurtzky himself. And those who don't know, John Kurtzky is obviously the very person who developed the EDSS, which used to be the outcome measure in clinical trials. Here's an illustration of the fact that this not only applies to the drug we're testing in Chariot, but this is natalizumab, so a compound that we use in highly active disease very early on. But it was tested in people with secondary progressive MS. It failed on the primary outcome, which was a composite outcome. You can see here there's no difference between the treatment versus placebo, but the NIHR PEC test, an upper limb function test, was clearly showed a difference in favor of treatment compared to the placebo arm. It was then not taken forward and is therefore not available for people with secondary progressive MS. But there's, in my book, no doubt that it does often have a positive effect. Similarly here for ocrelizumab, something that is obviously now licensed for primary progressive MS, on the primary outcome, or this is here the time 25-foot walking test, or a walking measure, but very similar to what was shown on the EDSS scale, which is a compound scale, about a 27% difference. But when you look again at upper limb function, there was a much more significant effect here. So this all kind of underpins why we think that time matters not only in very early MS, but it also matters in later stage MS. And so really the question is, what is early treatment? Here's one of our star patients, Mark Webb, who is supporting us. And just going to go over this to illustrate that we have now actually 22 sites open. Leicester has just joined as a site, and I hope that Agne and Torquay will also be part of the CHARIT-MS family very soon. I'm going to go over cladribine. This is the compound we're testing very quickly. It has been endorsed by the WHO recently as one of 3 compounds on the essential medicines list. This is the trial, placebo-controlled 2 years with the NIHR PEC test, upper limb function as the primary outcome. And so this is one of the really very unusual and novelties that we're focusing on people at later stage disease, and we have no upper age limit. That is also important here. Maybe I should stop here, otherwise I'm getting too much into my into this trial only, because there are also others. I might just go a little bit further through. And that is, for example, Octopus. Okay, so Octopus, a study that is strongly supported by the MS Society, a so-called multi-arm, multi-stage study, so where several compounds are being tested initially against placebo, but in the future may not be against placebo if the treatment arms work, or one of them works, and then it's kind of an open system where new compounds can be added or of course drop out if they are not seen as effective. It's a very expensive undertaking, but it's a platform, and other drugs can be added. This was based on a rigorous selection of compounds, and the first 2 are currently here in development. There's also an industry trial, so this is run by Roche, the OHAN study, including people with an EDSS of up to 8, so really with essentially one upper limb functioning very well, and so testing ocrelizumab at this advanced stage. And I had already shown some preliminary data suggesting that upper limb function may be able to perfect that for longer compared to the legs. So I'm just going to stop here for now to be open for further questions.
Yeah, I just want to just add, if that's okay, there are so many other competitive trials in progressive MS. So you name it, Sesamus, Octopus, Mastininib. There are some coded language trials that are not revealing the compound, the actual substance that are being trialed in progressive MS. And I think the whole purpose of all these trials to assess the safety and efficacy and the quality. And I think one against each other trial, what is fascinating CHARIT-MS is that there is no age limit, where majority of the trials, if you look at the summarized tables, they are up to 70, the max age. 65 is the common, that people are living long lives and good quality long lives. So, somebody 75, for example, wouldn't be able to be recruited to the certain clinical trial. So I think all the information is available, and we keep that information on our microsite, and we will share the detailed clinical trials listed with the purpose and medicine that are being trialed for you to get deeper understanding of that. Just want to touch a little bit basis. We had a few questions around regenerative agents in MS field. And I can tell you now that we don't use any licensed drugs. They are being under investigations in clinical trials. So should we cover a little bit on regenerative agents in multiple sclerosis?
Yeah, I think metformin is probably the one that is most, I'd say, investigated at the moment. I mean, there's a study in Cambridge that combines it with another compound. There's Octopus. There is a trial currently ongoing called Maximize in the Netherlands that essentially adds on metformin to disease-modifying treatment. It's a compound that's shown in the experimental setting, that it can facilitate remyelination. And this is now obviously a compound that many know from the diabetes field, well tolerated altogether. And it would be wonderful if something like this could be added on as a repair compound early on. I mean, maybe people now walk away and say, "Oh, I'm going to get some metformin in the next drugstore," and which is obviously their right to do. I think trials are there to really produce the evidence that it does actually work, and that we can, build a recommendation on that to use it. Alpha-lipoic acid, another one that is now being tested. Again, something I think that some people have already sort of taken off the shelf, but again, something that needs to, I think, needs to now show whether it does in fact do what people have suggested, that as an antioxidant, it is able to help protect nerves in the central nervous system. And there's obviously plenty more.
Yeah. There is a Cambridge Centre for myelin repair trial too. It's a phase 2A trial test. They are exploring again metformin and clemestin, which is antihistamine, to promote remyelination in people with relapsing remitting multiple sclerosis. They have very strict criteria for age, 25-50 only. Anybody above 50 are not being able or eligible to be recruited. And they look at the very sort of a specific optic nerve involvement into the whole process of multiple sclerosis. And so it's coming. We haven't got anything licensed as yet. People do take various different vitamins and antioxidants, but we haven't got a clear evidence-based information whether it's effective and produces some more energy for mitochondria and improves the cell replication and regeneration. So there are some stem cell therapies are also being explored in terms of the regenerative agent in multiple sclerosis, but it's early days for us to comment. We don't want to put ourselves in the position that we are providing no evidence-based information to you guys. So
I think that the problem there is often, I think, the misunderstanding between mesenchymal stem cells that are essentially directed at cell repair, myelin repair, or even axonal repair, which I think is really still a very ambitious goal. After many years, I mean, over decades of research, versus hematopoietic stem cells, which I think is much closer to clinical practice. In fact, I mean, many have undergone that treatment, and the STAR-MS and the matching trial in the US at the moment test that against the highly effective compounds that we have. And that is, again, very much targeted towards the inflammatory response, and to essentially really uproot that from very early stage onwards with, I mean, very promising. It's really only all you can say is really very promising results, because the controlled environment, the controlled studies are simply still outstanding, and we hope that they'll bring the answer whether it is indeed superior to what we currently have in terms of highly effective disease-modifying treatments.
So be careful going abroad having stem cell transplantation, because you might get wrong cells into your body, which might be very harmful and can cause the fatality. There are cases that had very poor outcome following the therapies, stem cell therapies in Brazil and elsewhere. So really you want to understand before you sign for any interventions. And currently in the UK, only autologous hematopoietic stem cell transplantations are available under NHS and clinical trial under the name as STAR-MS. Okay, so again, there is a strict eligibility criteria who is getting into this clinical trial. but it's worth knowing, and usually it's a failure of the existing high potency disease modifying therapy that you then are being recruited into the STAR-MS HCCT clinical trial. So moving on to perhaps, there are so many other clinical trials for relapsing remitting multiple sclerosis, but today's purpose is to discuss more progressive advanced MS disease. One maybe to mention quickly, as there was a question about, I'm interested to know if there are any trials for patients with RRMS, which is relapsing remitting multiple sclerosis, and any recent findings that will be available soon. So there are plenty, including BTKI inhibitors that we've mentioned that are for purpose of reducing the activation of microglia and smoldering MS, and we haven't got robust evidence whether it's going to work. We will get information around September time at ECTRIMS to know whether the medicine that works on microglia is effective. There is one clinical trial, Deliver MS, is comparing early intensive treatment versus evaluating later sort of versus escalation treatment. So early intensive or versus escalation treatment. So this clinical trial is interesting. Klaus also runs Attack MS clinical trial. Maybe mention that it's a nice forum. Klaus, to
Yes. Yeah, I mean, I spoke earlier on about sort of time matters, right? And we obviously we struggle sometimes with that concept in later stage MS. I think we don't struggle with that in principle with early in the disease now. Although I think there's still quite a bit of work to do for people to convert that or translate that into their clinical practice. And I'm sort of challenging really sometimes people just to think of MS much more along the lines of this, okay, which is obviously a stroke concept that we need to get onto treatment very quickly, and that we don't wait 3 months and 6 months and 9 months. And we're as you say, we're testing this now in a study called Attack MS, where we're treating people not necessarily with definitive diagnosis of MS, but with an 80% plus chance of that first symptom being part of their multiple sclerosis. And we're using natalizumab, which is a well-established and highly effective compound that many of us know very well from clinical practice since 2006, in fact, but it hasn't been used really in the setting of clinically isolated syndrome, where it could perhaps do the most good. Why did we choose this specific compound? Well, natalizumab has a downside, or a benefit that's usually considered a downside, which is that you have to give it quite regularly, every 4 to 6 weeks. But that also means that if the diagnosis should be like in 1 on 5 patients, not MS, you can easily pull out of treatment, and it is not so committed like with a compound like cladribine or a B-cell depleter, where you get a long-term effect. Okay, so this is really all about speed, and really tests very early treatment within 14 days of onset. This is the overview of the study, a relatively small study where we're testing natalizumab against placebo over the first 12 weeks. And then everybody gets on drug, and everybody also maintains the compound after they've finished or completed the study. We've negotiated that with the NHS to that they can continue on the trial. The primary outcome is here based on an MRI outcome. That is a repair measure. We're measuring essentially the effect on myelination using an MRI tool called magnetization transfer ratio, and there's a few other blood tests involved. So this is, I think, particularly important for people who have relatives or who have, I mean, people with MS who have relatives where they observe symptoms that might be suggestive that they do put them through to their GP or ideally to an A&E. If they have optic neuritis, go to acute eye care and have that assessed, because 14 days is obviously not a long time, but we did manage to enroll 11 people at this stage, and they have actually also completed the study. We had to suspend it because of an issue with drug supply, but we hope we will resume recruitment in the summer. So this is where we're going now, right? We're going to the very advanced stage, but at the same time to the very start. As long as we can't primarily prevent the disease, so through essentially eradicating MS, everything must be targeted of very early secondary prevention, and this is what this trial tries to underpin. So these are the 3 recruitment sites, but you can refer from anywhere in the UK to that study.
Yeah, it's really challenging to recruit for this study, but remember, people, time is brain, and the more proactive we are at the beginning, the better the outcomes. And we have real world clinical experience that we know that people who started disease modifying therapy early, they're actually running the companies and hospitals and doing various other things in their life without noticing the impact of MS. Why? Because they started their treatments within a month or so. And this is a great initiative run by Klaus. I think it's amazing if you can share this information on your media channels, spread across the globe. Basically, the studies in the UK, but just the more people are aware, they will pay attention that this is what they need to do. They need to be on the high potency drug, which is tisabril and natalizumab is classed. And as early as we can. This is something that I'm really passionate about. Now, moving on to the last 15, maybe 14 now, or 13 minutes that we've got left on a bit of a lifestyle. We haven't got many lifestyle clinical trials available in the NHS, but people are just putting questions around. Maybe first of all, I'll read through. I experienced some cognitive difficulties such as fatigue and memory issues that impact my ability to do my job effectively. I've been told that this is experienced by lots of MS patients, but I've not found any information that explains how and why. Can you offer any insights in how to explain this to employer? Maybe whilst Klaus is thinking how to best answer this question, I'll start that cognitive difficulties, including fatigue, memory issues, are common in MS due to the disease impact on the brain and central nervous system, mainly. And these issues stem from the demyelination and nerve damage, which can disrupt the communication and neural nerve cell communication between each other. And when you're explaining this to employer, highlights the medical nature of these symptoms and variability, because one day, there are good days and bad days. This is what we learn from our patients. And I think that education and knowledge is the key, and resources about MS and giving that to your manager at workplace, and what managers do these days. And sometimes the clinical team, like consultants and nurses, could send you a support letter, and the workplace usually accommodate, give you flexible hours, you may have regular rest breaks. It sort of affects your productivity and performance, and if you don't get enough rest throughout the working hours, so you can really feel. And how we advise, to manage the fatigue, which is very, very common symptoms. So you have to be mindful in terms of the energy conservation. How do you preserve your energy levels? Exercise helps a lot to help and improve the energy level, and sleep hygiene is super important. If you don't sleep very well, of course, you have a knock-on effect throughout the day. Some of the medications can also give you sleepiness, like one of the commonest one that is in my mind at the moment is baclofen, for example, and so many other neurological medicine that can affect your wakefulness. But there are medicine that you can discuss with your doctor, neurologist. It's called amantadine or modafinil, and also very, very important that it's close to my heart is diet and balanced diet, avoiding sugar, coffee, 8 coffees a day is too much, so you're draining your battery, and stress management would be something that we would highlight during the clinical consultation for people to get that help. And of course, some mind work, mindfulness, meditation, CBT would also help you with the fatigue management. Any other extras to add, Klaus, in terms of the fatigue? It's the commonest symptom living with MS, as far as we know.
It's amazing. You've brought up already the so many elements. I think what we perhaps haven't mentioned so far is that there are, medical interventions. 2 of them. Let me just go back to that slide here. This is a little bit an illustration of what people often feel even when they've had a good night's sleep. And this is from just a survey that we once did on the blog, and you can see how high that features as a disabling symptom. And if people with MS are on the call, they know exactly what we're talking about, and we're carrying kind of coal to Newcastle. I think one element that is important is medical intervention are possible, although they're not sort of a one for all and not always effective, but we do use drugs like amantadine or modafinil in fatigue management. And the other is, I think, really to look very closely into sleep and other adverse factors, because people are often on compounds, medication, for example, for their bladder, for their sleep, that all impact on wakefulness and fatigue as well. So that is incredibly important to really look through the pharmacy, what is necessary, where's the best kind of compromise for the individual. Exercise, I think you've already mentioned, of great importance as well. And that's obviously also often a double-edged sword, right? Because exercise can lead to tiredness. So it's about really how to feed that into your schedule during the day, to optimize that.
Yeah, there was a question around, can I exercise after the relapse? It's must. This is must what you need. It's a disease-modifying approach. This is the only one lifestyle approach that is classed as highest evidence that actually improves the neural circuit of the pathways, that you get a really positive outcomes in terms of your emotions, feelings, and your physical abilities. So the earlier you start, but you start with gradually with the small steps, and then you increase it as the time goes. So don't overstretch yourself. Don't overdo things, because there is an element of the Udhoff's phenomenon that you may feel that temperature is rising, you get worsening of your symptoms, and that may scare you. But you're not damaging anything. It's just a phenomenon that is well known, and you're really gonna only nourish your body and mainly brain. The function will improve over the time, and this is a very strong evidence that we have currently available from the clinical trials and research available. In terms of the diet, numerous amount of questions around the diet. Should people with MS avoid dairy products? There is one of the famous diet, Overcoming MS diet, that recommends people to avoid dairy. Again, we haven't got any robust evidence in terms of how it's going to change the trajectory of your disease. Some people have improvement in symptoms, but bear in mind that a lot of even normal population of people have lactose intolerance in general. So people develop IBS type symptoms, and once they stop consuming dairy, they get better anyway. So not necessarily linked to MS, and there is no robust evidence to say that is going to slow down the progression or change the whole sort of trajectory of the condition or diminish relapse. Is not enough evidence to support that. Anything on the diet to add on?
Yeah, I'm a little bit with Brandon Bieber here in that, I'd say, you have to eat something, and you might as well eat something healthy and balanced. I think this is the first thing to say. This is from the MS Society's website, so they have quite a good sort of overview of special diets as well, that you can sort of dig through. I've just brought up the original paper by Roy Swank, because many obviously it's got quite a large following, and that is very much fed into George Jelinek's ideas in overcoming MS, of the low saturated fat, but also very low dairy, in fact, of zero dairy diet. I think that the one element here is obviously there's been no real control arm in the study. It was a very long study. I don't want to sort of, poo-poo it for what it was at the time, because it started incredibly early in the 50s and was a very long follow-up period. But I think this is simply one of the weaknesses that people would mention. And I think also it's important to remember that the diet and overcoming MS themselves highlight that the diet let people get actively control of their illness with a lifestyle change, and it is part and parcel of a whole program. It is not the individual and only element. Just as we would never claim that disease-modifying treatment is the one all, and sort of the sole element of your management. It neither is, I think, the diet. So it's not all diet. And in fact, there's been a very recent review that also looks at the association between diet and disease progression. And I'm afraid to say what they end up with is we need more research into the topic.
Yeah, some emerging evidence that ketogenic Mediterranean diet and intermittent fasting shows some promising results, but early days to say that, as it's difficult to organize one robust trial to prove the efficacy. So it's, at the end of the day, it's a complementary besides the compounders such as disease-modifying therapy. So being mindful and introducing the lifestyle. Diet is just a small drop into the whole ocean. So, but being mindful about what you eat is super important, as everyone knows. But it's just finding that energy to implement these changes throughout the day is another topic, which is analyzing people's behavior living with MS and how we respond to the stress, and sometimes we filling the emptiness in ourselves with the inappropriate diet. So, but bringing that awareness each time is a good start. So we are very limited with the timing. We are running into 6 p.m. And thank you everyone for joining us today for this insightful webinar. I hope you found this insightful, and under the name of Ask the MS Expert. We hope you found the discussions valuable and informative. So very special thanks to Professor Klaus Schmierer for sharing his expertise and answering all these interesting questions and sharing the slides and sharing his very informative, in-depth information that we just received. I do appreciate that. His contributions have been very beneficial in enhancing our understanding of multiple sclerosis and its management, as you all probably agree and nod at the moment to me. I can't see you, but I feel that. So as we conclude, I encourage you to stay connected and continue exploring the latest advancement in MS research and the treatment. For ongoing updates, resources, you can follow Professor Schmierer on the BartsMS blog and other media platforms that he's very active and present. As well as you can sign on Southwest Research microsite for the website that we shared at the very beginning in the chat. You will receive some updates on the research and any further future events that we run. We're planning to run that regularly. If you have any additional questions or need further information, please feel free to reach out to us, and we are here to support you in your journey living with multiple sclerosis. So thank you once again for your participation, and we look forward to seeing you at our future events. Stay well, take care, and good evening, everyone.